Only mode.
Hello everyone, welcome to another webinar here at the Southwest Ontario Base Hospital program. I'm Matthew Davis, Medical Director of Education, and today we're joined by Dr. Bourke Tillman, who's a PGY4 in Emergency Medicine and also a Critical Care Fellow, and Dr. Mike Lewell, the Regional Medical Director for SWORBHP. And today we will be discussing stroke. Just a few housekeeping items before we begin the actual presentation. For those who have never attended a webinar before, you'll notice that there's a PowerPoint presentation being presented here today and also a control panel. If you have any questions throughout the presentation, please feel free to enter it into the chat box and we'll be able to answer those questions live. For those of you who have a microphone with your computer, there's also a hand icon which you can press and you can actually ask the question live. Throughout the presentation, we'll have a series of poll questions. So please stay by your computer to answer those poll questions for us. And if it's a group of you who are watching the presentation together, please let me know through the chat box so that I can give everyone their appropriate CE credits for viewing this webinar. So thanks for joining us, and without further ado, here is Dr. Tillman and Dr. Lewell.
So good afternoon, everyone. Seeing as it's a Monday, I thought we'd start with a few cases just to help us wake up, because I know that I don't do anything functional on a Monday. So let's see how far we can get. So the first case is a 52-year-old male. 911 is called, and the friends sort of give a history of clumsiness. When you arrive on scene, the friends tell you that he's been there since 1900. At around 2100, he was able to pick up his right hand and started drooling. Didn't have any trauma, had one beer. His friends are sort of making fun of him for being drunk after one beer, but then got concerned. So on your exam, you notice that his vital signs are normal. He's afebrile. His glucose is 5.8. But he has slur in his speech. His right face is a little drooped, and he has some right arm weakness. So from here, we'll pop up a quick question.
So our first question, why are these findings suggestive of a stroke? A, stroke is the only cause of these findings. B, they relate to a specific area of brain function. Or C, they are not suggestive of a stroke. And if you could please enter your response. And so we have 89% with the correct response of B, they relate to a specific area of brain function. And we'll get back to Bourke here in the presentation.
Awesome. So that case went pretty well. We'll go on to a second one. We're called by a retirement home, and the staff says, I think our patient had a stroke. Can you come and take a look at her? So when you get there, you find out she was normal when she went to sleep around 2200. This morning, nursing staff went to check on her. They found she was aphasic, and she had a pretty decreased level of consciousness. There was no history of trauma, and all the medications are administered by the staff, and they've been administered appropriately. On your exam, you find there are vital signs within normal limits. She's not tachycardic. She doesn't have a high rest rate, but she is febrile at this point in time. Temperature's around 39. Her glucose is 8, and when you do a physical exam, the patient's mumbling, and she withdraws to a painful stimuli. So we'll follow this case up with a question as well.
So our next question, why does the patient not qualify for stroke bypass? A, because the time is greater than 3.5 hours since last seen normal. B, lack of focal deficits. C, GCS less than 10. Or D, all of the above. Just give you another minute to get the final votes in here. So the correct answer is D, all the above. We have 53% getting that correct answer.
Look, one of the confusing things about this case would be the aphasia. If the aphasia is pure, that could be actually represent a focal neurological deficit, but this patient is actually mumbling here at the bottom, so therefore, most likely it's still able to have some sort of voice.
That's quite right, Dr. Lewell. It's always confusing, especially when a nursing home staff calls you and sort of leads you in one direction. And that's why you have to rely on your exam and see how they react to you when you speak to them.
Especially with her being febrile and mumbling, you wonder about other diagnoses such as confusion or delirium or sepsis or infection, especially with the decreased level of consciousness. Very good. Okay.
Quite right. And we'll go on to our third case, and then we'll go into the meat of the presentation. So for this third case, he's a 60-year-old male who lives at home, and he called 911 himself because he couldn't move his arm. So the history you get is he was normal when he went to and left work, and then he had a sudden onset of chest pain and decreased sensation in his left arm around 1100. On your examination, he's tachycardic, he's hypertensive, but he's afebrile. His glucose is within normal limits at 4.5. He speaks in full sentence, but he tells you in all sentences that his chest hurts and his arm is numb. So we have one last question here.
So our last poll question for this series, what is the most likely diagnosis? A, stroke, B, aortic dissection, C, seizure, or D, myocardial infarction? And we'll close the poll here. We have 100% actually responding myocardial infarction. Bourke, do you want to discuss the answer for this one, please?
Certainly, Matt. So myocardial infarction is definitely on the differential here, especially with the sensation of chest pain going into the left arm. The other answer that should also be considered, especially because we're talking about neuropathology in this lecture series, is the fact that he does have a neurological deficit, being the arm numbness. And when you start to deal with chest pain and arm numbness, you want to think of other pathologies that can also interfere with flow to the spinal cord and flow to your neurovascular anatomy. As such, aortic dissection also plays high on the list. But I don't think anyone would fault you for considering a myocardial infarction in this case.
Absolutely, and the challenge here is the arm numbness. So if he's lacking blood supply to his arm, perhaps he has loss of sensation, but it's actually not a motor deficit. But if you have an ischemic limb, you certainly get loss of sensation, then progress on to a motor deficit later on. And a sudden onset, coupled with the hypertension, makes you concerned for dissection, but nevertheless, absolutely. I mean, a myocardial infarction is the number one thing to get distinguished between, and the number one thing on the differential between dissection and acute MI. So very good, very good.
Excellent. So from here, we'll go on to the meat of the lecture. So by the end of this webinar, our hope, if I do my job right, is that you can identify sort of the common clinical findings of a stroke. You might be able to describe some of the relevant pathophysiology, summarize the pre-hospital assessment and care for stroke patients, and then we'll take some time to review stroke bypass protocol, especially as it relates to us in Ontario. So what has been released by the AHA is a simple stroke assessment tool. As notes, it has a few signs, how to assess it, and what you'd expect to find in a stroke. The big thing is to realize that all of these, except for the slurred speech, share one unique feature, and that is that they represent unilateral deficits. The reason for this relates to the physiology of the brain, and that is why we have to discuss some pathophysiology. So grab a coffee and try and stay awake with me. So when dealing with the brain, we always review it's done in 2 hemispheres, 4 lobes, You always think the right hemisphere controls the left side, the left hemisphere controls the right side, and then we discuss how the right hemisphere is maybe a bit more creative and the left hemisphere tends to do speech and numbers. And that's why when you look at your stroke assessment tool, that aphasia comes up, because although it's not a unilateral finding, it's a unilateral deficit in the brain itself. Now, aside from the two hemispheres and the four lobes, we also consider the lower parts of the brain, which are the cerebellum and the brainstem. When dealing with strokes in this area, findings are a bit more confusing, and we don't generally keep them as high up in our differential, but definitely need to be considered. So a cerebellar stroke tends to be the person who looks drunk. They have problems with their balance, their gait, and they usually complain of some vertigo or nausea. When you look at a brainstem stroke, these ones can be quite challenging to diagnose and tend to be easily missed. These patients can have problems with their consciousness, with their cardiac regulation, with their respiratory regulation, generally just control of the autonomic nervous system. Now the other part of anatomy, oh, this is different than this slide. Sorry, my two slides are different. Anyway, so when looking at a patient, you have to consider what side are we dealing with the stroke on. So if the stroke is in the left hemisphere, you expect to have right side deficits. I know for me, it took me forever to remember. The other issues they present with are aphasia, because remember, the left side deals with numbers and words. And the neat little thing to try and remember is the eyes tend to look towards where the problem is. So if you have a stroke on the left side, your eyes tend to look to the left. Everything's the opposite on the right side. So if they have a right hemisphere, their left side is weak, and they tend to look to the right. So generally remember, right side symptoms, left side stroke. Left side symptoms, right side stroke.
Sometimes they actually talk about the patient will actually look away from their side of paralysis with disgust. So if you're looking at a patient who's had a major stroke, many times you walk in, they're not moving the right side at all, and they're looking to the left. So they're looking away from their side of paralysis, and vice versa. And it's actually important for the rescuer or the attending physician when you walk in, because you'll notice that they may actually not notice you. So if you approach them from the paralyzed side, they'll be looking off to the right, and they actually don't even see you approaching them from the left, and they'll be looking around to where that voice is coming from, and you may misinterpret that as a decreased level of consciousness or someone who's not responding, but that's really someone who just is wondering where the heck that voice is coming from and looking all around. So it's important to approach them from both sides if they don't seem to be responding to you initially.
That's definitely a very important point and something that's easily forgotten in dealing with these patients. Now, the other issue that we talk about, and a lot of the ways we describe strokes, is in their blood supply. The reason for this is a stroke is what impacts blood supply, so we talk about it in the different regions. If you look at the brain, you see that there are three main arteries, being the anterior, middle, and posterior, and each one of these tends to supply different parts of each of our four lobes. Aside from supply to your lobes, you also supply to the cerebellum and the brainstem. In this situation, we're still looking at the posterior cerebral artery, but we also include the vertebral basilar artery system, which, as you see, runs up in the spine, by the spine. So when we're thinking about deficits in a stroke, what we're actually describing is the areas of the brain affected by interrupted blood flow. Therefore, it is important to remember what areas of the brain we're dealing with and what blood supply goes there. So as I said earlier, due to the unique blood supply, strokes can be described based on the affected arteries. We can take a second look at the cerebral blood supply. So here people talk about an ACA stroke. What they're saying there is this picture. They're considering frontal lobe symptoms and superior medial parietal lobes. That tends to be along the motor and sensory strips in the brain. So that's when we talk about this homunculus picture, or having problems with a specific limb or a sensation in that specific limb. That's because this is the area of the brain supplied by the ACA.
Can we just stop here for a second? When I first saw this picture, I found it very confusing. And really, if you look at this picture of the brain, what it is, it's a patient that is actually sitting on top of your brain with the leg dangling into the cleft, the central fissure. And then as you lean back, your arms and then face come down the side of the brain. So effectively, along the middle cerebral artery territory is where your face and arms are. And as you're going to allude to then, if you ping off one of the blood vessels in your middle cerebral artery, you're going to have more face and arm weakness. Whereas if you're in the cleft where the anterior circulation goes, that's going to affect, as you can see in this diagram here, more of your legs. Now, I often said, like, if you go to like a nursing home and you're walking down the nursing home, you see someone in a wheelchair, and you think, why aren't they ambulatory? Yet they look at their face and you look at their arms, they have full function there. You think, well, that person's had a stroke, but the reason they're confined to a wheelchair is because they've had an anterior circulation stroke, and they have no external signs apart from their leg paralysis. Vice versa, you go to the mall, you see a guy walking down the mall, and he has arm weakness, it's all flexed and atrophic because it's been stuck like that for a long time, and he has a facial droop, yet he's ambulatory. That's someone that's had a middle cerebral artery stroke. So knowing the territory and knowing the physical findings helps you understand where most likely the lesion is going to be on the opposite side. I think this diagram is very important. It's just that it's really overwhelming when you first look at it.
I completely agree with Mike as he steals my thunder of my next slide.
You're welcome.
Which is going to go into the MCA. But I think it's more important to remember that picture because I find it very hard to memorize a list, but I can think of a picture of someone leaning back. It's also important to realize that knowing the pathophysiology and knowing the cerebral artery territories helps you recognize a stroke. That helps you pinpoint a unilateral deficit and have a better idea of what one is. So we look at the middle cerebral artery, once again, we're looking at upper limbs, we're looking at facial problems, and we can even get into speech impairment, and as we talked about earlier, neglect and spatial disorganization, which means they don't see things or can't look towards that paretic side. The last area we talk about is the posterior cerebral artery. This is the artery that supplies the back part of the brain as posterior states, which is where your occiput is. It's the area that controls vision. I always find this a difficult stroke to characterize due to there are multiple types of blindness as well as just loss of recognition, which can be quite confusing and also make it very hard to even tell the patient has had a stroke. So this is once again why it's so important, as Dr. Lewell alluded to approach a patient from both sides, because your only clue may be they don't see you when you come at them from one side. As you notice, there aren't many motor signs related to this. So this patient's only deficit may be that they now are blind in one visual field.
You're absolutely right, Bourke. We're really good at picking up the motor strokes. Those are the ones that the patient's complaining of. We examine them. They're not moving one side. And quite honestly, a lot of us are very bad at confronting people's visual fields or looking at their coordination what may be impaired or their ability to be slightly more unstable in their gait, especially elderly impaired patients perhaps. So posterior circulation strokes where you affect balance and vision and coordination, those are really difficult to pick up, yet equally as important.
I fully agree. I'm sure I've missed more than one.
Shh, we won't talk about that.
And the last area, well, the second last area we're talking about is the cerebellar stroke. Again, we're usually looking at the PCA, but the signs and symptoms are a bit different. The cerebellum isn't controlling your vision anymore, but instead is more a gait and vertiginous sensation. These ones I find we're a bit more attuned to because patients do complain of nausea and an inability to walk. So we look for these a lot more often than the PCA, but they still are a challenge to find.
It's funny, you talk about the cerebellar stroke being drunk and poor balance. I don't see like other sort of drunk symptoms like poor decision making and gambling, compulsiveness, and other things. I don't see anything associated with this type of stroke.
Surprisingly, that's a frontal issue and nothing to do with the cerebellum.
Oh, okay. I guess I don't have an excuse. I thought I had a posterior stroke a long time ago.
You can't blame that. You're sick.
Too bad.
And then the last area is the brainstem stroke. These ones are much harder to pick up. They're harder for us to even see when we image them, and they tend to be found later on when the patient gets an MRI. These patients have a decreased level of awareness. They have problems with auto-regulation, so you see odd blood pressures, odd heart rates. They have respiratory depression. Usually their GCS rules them out of stroke bypass anyways. The sole fact that this stroke symptom can be confounded with so many other diseases that it's just not feasible most of the time.
I think one of the most important things I was taught when I was learning about stroke was that because stroke happens classically unilaterally, so the left or right hemispheric, not typically the brainstem, which is more of a central thing, Therefore, since it affects unilaterally, you should not really have an impairment of your level of consciousness. So to really be impaired with your LOC, you need to have a bihemispheric insult, so something that affects both sides of the brain. Therefore, if someone's unconscious, or similarly, there's no one blood vessel that controls your blood pressure. So if you're unconscious or you're unstable from a blood pressure point of view, it'd be really hard to imagine what blood vessel did you occlude that's now caused you to be unconscious and hypotensive. So since there is no real blood vessel, apart from maybe your brainstem like this, like a pontine or a brainstem hemorrhage, pretty much think of alternate diagnosis if you're hypotensive or you have a really impaired level of consciousness. Because it just doesn't make sense.
I completely agree with that, and I find that it's something I get harped on a lot by my staff and have to talk with my juniors about a lot, because we tend to say, oh, a stroke is the cause of that person's decreased level of consciousness. But that is very rare and probably shouldn't be the first diagnosis you jump to.
Unless, of course, we will talk about a different variant of stroke, which we're going to come up to later on in our presentation.
Yeah. So we're actually going to go on the types of strokes right now. What we're talking about here is what has interrupted the blood flow. So usually we think of a clot that has gone into the artery and isn't allowing proper circulation, and that's the ischemic stroke, and by far the more common. The other type of stroke is a hemorrhagic. We won't devote much time to hemorrhagic strokes in this webinar, although it will be discussed later. When we talk about hemorrhagic stroke, we're talking about a bleed, so that blood again is not getting to the tissue and supplying, and that part of the brain is dying.
And that's the kind of stroke that you may actually see an impairment of consciousness if they have a sudden catastrophic loss of consciousness. And you have to wonder, because these bleeds may not necessarily follow the same territories as the hematoma expands. It may not be the same territories if you occlude a blood vessel. Therefore, they may have herniation or occlusion, or they may have obstruction of their ventricle with hydrocephalus. Therefore, they may have a level of consciousness which is impaired, unlike the classic ischemic stroke you're talking about here.
Exactly. So we are going to focus on ischemic strokes today. So it falls in the same pattern of decreased level of consciousness, probably not an ischemic stroke. So when we think about how common is ischemia as a cause of stroke, it's probably about 80% of strokes. As I said, we're talking about a blockage of an artery either by a thrombus, so think something like a heart attack, a plaque rupture, or an embolism, something similar to a PE. So what causes thrombus? Arthromas and vascular inflammation. What causes embolisms, which usually are more common? AFib is the big culprit, but someone with a recent MI and have recent surgery are also at high risk for this. As we alluded to, hemorrhagic strokes do occur. They're about 20% of our strokes. They cause an arterial rupture. Primary causes are chronic long-term hypertension. It's not a quick increase in blood pressure a single day, but someone who's had hypertension for years. This can also happen in anticoagulation and platelet therapy, certain drug use and bleeding disorders. When we talk about anticoagulation and platelet therapy, it can also be caused by thrombolytic therapy as well, which we'll discuss when we go on to treatment of strokes. Secondary causes can be vascular malformations and tumors that are occurring in the brain itself.
So I'm going to jump in here with our next poll question. So the question is, only ischemic type strokes qualify for stroke bypass. A is true and B is false. Let's give another couple of seconds for those who haven't answered to answer. And it's a tight race here. We have 58% stating false and 42% stating true.
So this is a very difficult question to answer, because really we're doing our stroke bypass based on symptoms, not the known pathology that's going on inside their brain. So I think the important thing to consider is not what type of stroke it is, but how they're presenting. Once you get them to the tertiary care center, the workup for hemorrhagic versus ischemic stroke will be done. But this is helpful to help you think and look through how are they presenting to us. Dr. Lewell, do you have anything to add to that?
Yeah, the way the stroke, well, as we talked about, the stroke bypass card actually is framed such that things that are more common in bleeding type of strokes or hemorrhagic strokes don't usually qualify for the bypass, because what we're looking for there is who we're going to thrombolyse. We're clearly not going to thrombolyse a bleed. So of the presentation list, some things that are more associated with bleeding, such as seizure or decreased level of consciousness or pupillary findings or major sort of coning style pictures are things that don't qualify for the stroke bypass. Therefore, although you won't know pre-hospital which one's an ischemic, which one's hemorrhagic, things that are more likely associated with hemorrhagic are usually exclusion criteria on the compound.
And I think that's the best way to look at it. In fact, what we need to do now is apply this passive physiology and my knowledge of English language in this presentation to what we're going to do on scene. So the reason we go through all this pathophysiology is just to increase the chance of recognizing a stroke. And that's the big issue. So we can take a second look at the stroke tool. Facial droop helps you think, well, maybe this patient's having a stroke, and you'll now have a better idea that maybe the territory here is going to be the MCA. Leg weakness, we can start thinking about ACA. Arm weakness, maybe MCA, maybe ACA. And this slurred speech, probably MCA. And we think about it.
Or it could be cerebellar.
Or it could be cerebellar,
yeah.
For sure. These are the more common strokes you will see. And the big thing that I will probably harp on this entire presentation is looking for unilateral deficits. That's what's going to tell you this is following the blood supply. That's going to tell you it's usually the brain that is the cause for this. That being said, there are lots of stroke mimics in the world. And hopefully some of the stroke bypass protocol is going to help you differentiate the two. You can see these in many, many different scenarios, such as infection, hypoglycemia. I don't need to read the entire list to you. I'm sure you read as well as me. The end of the line here is if the patient has an altered level of consciousness, as Dr. Lewell has brought up a few times, you really need to think twice and ensure that your examination is correct.
And also, these are patients you want to transport 2 hours, potentially up to 2 hours, to the stroke bypass if you have an altered level of consciousness. Even if they do have an underlying stroke, perhaps that person should have their airway secured and look at the facility transport to get them if we're really concerned with your airway.
That's for sure, because we want to take care of the patient the best we can. So what do we want to do when we're on scene? Let's remember that we agree time is essential, but a detailed history focusing on a few key factors is equally as essential. First of all, you want to know when was the last time they were seen normal. The common question is, well, they went to sleep normal. What does that mean? You do have to start when they went to sleep, and we'll discuss why that's so important when we discuss thrombolytics and therapy. You want to use a combination of your history and physical exam to have to understand what their symptoms are, to go back to my favorite term, which is unilateral deficits. And then it's always nice to know if they do have risk factors, because that may help you seal the diagnosis or really firm up, as well as have you ruled out possible mimics. So is this patient seizing right now? Is there glucose in their boots? Do they have a head injury? Those are things that will allow you to move away from the stroke path.
Well, all the things that the stroke neurologist identify as one of the reasons they cannot receive a thrombolysis, it is this time last seen normal. They can't necessarily verify either from the EMS record, the paramedics themselves, or else from the actual family members, when was this patient last seen normal? Because if it's not within the window, the risk of bleeding, as you're going to allude to, just goes up enormously. So that is a key element, is the last seen normal. Excellent.
So what does our rapid examination include on scene? It includes a general assessment, which is ABCs, as well as a GCS, checking the patient's glucose. I know that I've intubated my share of hypoglycemics. Luckily, I have not thrombolysed them yet. And then you need to determine if the patient meets our bypass criteria. So how does the AHA describe what we should be doing? They again recommend the first thing you do is assess and manage ABCs. This is like any other patient. You don't need to take interventions for hypertension unless, of course, you speak to a medical directive on that. And in fact, their blood pressure may be providing perfusion to their brain. So it's an area we use treatment quite judiciously. You want to have some good monitoring, establish IV access as per your protocol, determine the blood glucose, and treat accordingly as correction of a blood glucose issue may eliminate all symptoms. At this point in time, you want to determine when the symptoms onset and when they're last normal, and then you can work through triage and notification.
It's interesting, Bourke, on this slide they identify right on the first line that hypertension is one of the most common findings of stroke, which is absolutely true. It steers so much further away from the fact that hypotension should not be associated with stroke classically. And the reason being, as you well know, that hypertension is often a reflex that the patient will have to either offset to maintain cerebral blood flow in the setting of raised intracranial pressure. So if you have elevated blood pressure, it may tip you off that actually there may be raised ICP, which actually may fit with the bleed, or may fit with the body trying to compensate to say, hey, look, why is part of my brain not getting blood flow? Therefore, they actually drive up your blood pressure. So hypertension, quite associated with stroke. Very good.
So from here, we'll move on to our stroke bypass. So when we go through our protocol, this is the first page you see. You want to find a patient who, first of all, has the correct symptoms. Again, unilateral comes up in everything we discuss. It may just be slurred speech as well. It may be a facial droop. It may be the arm, or it may be the leg, but it is a unilateral deficit. The other issue is time to transport. You need to be able to get this patient to a designated stroke center within 3.5 hours of a clearly determined time of onset or when they're last seen in normal health. Again, that deals with our treatment, which is thrombolysis. We'll discuss that at the end of the lecture, but if we cannot give thrombolysis in an appropriate period of time, the risk of causing hemorrhagic transformation is much, much higher and outweighs any benefit of giving thrombolytic therapy. Now, the other part to stroke bypass is, of course, contraindications. The first part of this is any uncorrected ABC problem. As remember, we're trying to treat a stroke to do best for the patient, but if you can't fix their A, B's, and C's, it doesn't really matter if you fix a bleed in 3 hours. Also, CTAS level 1 patients fit in that same category. If the symptoms of the stroke have resolved prior to your arrival or prior to the time you've assessed them, then we're not going to be fitting that patient the stroke bypass. Note, this is prior to arrival. If they improve while you're transporting them, you will continue your transport. We also touch on blood sugar. Hypoglycemia is a contraindication, as this needs to be corrected. Hypoglycemia presents commonly as a decreased level of consciousness or some odd neurological deficits. If you see a patient seizing, then you have to start wondering, is there another pathology going on, or is this worse than we think? Again, decreased level of consciousness comes up. Terminally ill or palliative care patients is very hard to determine, and you may not be able to tell at your point in time, and they may get transported. Also, to think of how long your duration of transport itself will be. The longer it takes to transport, the less time you give the receiving physicians.
So one of the big questions that keep coming up with this list is, so CTAS 1 for sure, unstable, closest hospital. You'll notice that the blood sugar cutoff for treatment here for bypass is a different number than we actually have for our advanced medical life support patient care standards, which talks about a different number. And this is because they're not developed in parallel with the protocol. So this is created by the Acute Stroke Network based on evidence, and this is what the stroke neurologists want to see, and therefore that is different than the same line we have for treatment with regard to advanced life support patient care standards. But we will not transport patients less than 3. Another thing is seizure at onset by the paramedic. That's actually more associated with bleeds. And also if you seize, you're going to have an impaired level of consciousness following that, and these patients shouldn't be driven up to 2 hours. They probably need to get to the closest facility. And terminally ill or palliative care patient is not the same thing as a patient that has an authorized Ministry of Health do not resuscitate form. There are many people out there in the community that are not terminally ill or not palliative that actually have valid DNRs. It just means that they've experienced enough life events in their life that they're happy with the fact that if they have a cardiac arrest, you don't attempt to resuscitate them. Many people will still actually thrombolyze a DNR if they're still active and healthy. So this is designed to be able to say, this is someone who's living with terminally ill, metastatic carcinoma in a hospice that developed an acute neurological phenomenon. Well, sure, that person probably is not going to be thrombolyzed. Or if they're actively receiving palliative care, their life is expected to be ending in the near future, these aren't patients we're looking at thrombolyzed. But the DNR does not preclude you from being a thrombolytic patient. Therefore, it does not exclude you from the stroke protocol. So it's great review of that, Bourke. Thank you.
I think the DNR always brings up questions, and it's something we definitely need to consider and understand that there's a difference between do not resuscitate and a terminally ill patient. They are not the same. So what are the key points really in this whole stroke bypass? Their symptoms need to fit with a stroke. Again, unilateral. I can't say that enough. And then you have to be able to get them to a stroke facility with enough time for them to be appropriately worked up and for therapy to be initiated. So if it's going to take too long to drive there, it doesn't make any sense to bypass other facilities.
So just going to jump in here, gentlemen. There's a question from the audience, and the question is, with hemorrhagic strokes, is it possible to see Cushing's triad symptoms in regards to vital signs?
The answer is most certainly yes. Cushing's triad is related to an increase in intracranial pressure for any cause. And blood in your head is a darn good reason to increase your intracranial pressure. So you for sure can see Cushing's triad. That's going to include hypertension, bradycardia, and an interesting breathing pattern.
Very good, very good.
And now, the other issue that comes up, has been brought up by the stroke protocol, is this time of onset. We want to know when they were last seen normal. The reason for this is current treatment of acute stroke is the use of recombinant TPA. This is a thrombolytic. The problem is the longer you wait since the onset of stroke, you increase the risk of hemorrhagic transformation. And the higher the risk of harm. And our first rule is to do no harm. So if a patient has had stroke symptoms upon waking, we have to assume the stroke happened when they went to sleep, because it is unsafe to be putting these patients at the risk of having a bleed into their brain. That's going to be in thrombolyzed blood. That's going to be very difficult to control. The other issue is what happens if they come back to normal while we're transporting, and then they get worse again. The clock has now restarted because that is the last time they've seen normal.
This is oftentimes a source of confusion because we don't transport those patients whose symptoms have resolved prior to us arriving or during our assessment. But upon transport, the patient actually has resolution of their findings. As Bourke alluded to earlier, you're supposed to continue on to the destination. And the reason for that is many strokes will actually start and stutter. So therefore, you may have an issue where they have the neurological deficit, it resolves, but then you decide not to continue on with your transport. Well, then it recurs again, and you can get that much closer to the neurocenter had your thrombolytic administered in a faster time frame. So this is by design by the neurologist. They want, if it happened that you were able to assess them and they clearly met the criteria, then you continue on with your transport, even if their symptoms seem to resolve. Very good.
And the last part is the contraindications. Again, the key point is this patient has to be stable enough for a safe bypass of closer hospitals. You don't want to be transporting an unstable patient or someone with no airway and driving past 3 hospitals on the way. You want to ensure you can't readily identify a mimic. Sometimes mimics are not readily identifiable, and that's okay, but look for hypoglycemia and seizures. And you need to be able to reach that stroke facility with enough time for the neurologist there to appropriately work the patient up. Now, before we do a quick review of what we discussed in this webinar, I want to leave time if there's any other questions.
Actually, there is a question that just came in from an audience member, and the question is, if the glucose is less than 3 and it resolves after using or administering dextrose, if they're still presenting with stroke symptoms at that point, can the patient still be transported under the stroke protocol?
So that's a very good question, as you have treated the hypoglycemia. But the answer is still no. The reason for this is there could be numerous reasons for why they were hypoglycemic, and those causes of hypoglycemia may also be altering the level of consciousness. So at this point in time, this patient has a very metabolic type derangement and likely requires workup from that side.
It also could be that after treating them, it takes a while for those neurological symptoms related to the hypoglycemia to improve. So you may, after giving the dextrose, you may notice that it takes a while for their neurological changes to resolve. And remember, too, stroke bypass can actually be secondarily activated by a local emergency physician as well. So you brought in a patient with an ultra GCS and a blood sugar less than 3 to your local hospital, and if despite normal glycemia now and the assessment of the emergency physician, if this person still has having a stroke, then they may actually secondarily activate the protocol. But at this point, it's closest hospital because blood glucose less than 3 is a contraindication. Great question.
Excellent. If there are no more questions at this point in time,
We just had one come in here.
Matt, there are no more.
Well, one
Okay.
just came in here, so just give me a second to review it here. Someone has written in about the AHA guidelines, stating that somewhere in there that they believe there's a table which shows that if you establish an IV before taking a blood glucose, can you comment on that? I'm not exactly sure what that question is asking. Perhaps you could clarify that for the person who sent that in.
Yeah, man, I'm not sure what they're getting at with that question.
We can answer that offline. There's always the Ask Mac. If you have any questions for Ask Mac, you can definitely put those questions in through there. And seeing as we don't have any more questions, we'll wrap up the webinar.
So we'll just move on. We'll quickly review the 3 cases we addressed at the beginning. So case 1, as you go through your exam, the patient does have normal vital signs. They're not febrile, and they are normal glycemic. Furthermore, their level of consciousness is not impaired, and you see these deficits are all unilateral. This is a patient who is quite concerning for stroke and is only 2 hours since their event. As such, given the distance from your stroke center, quite likely will meet stroke bypass criteria. In contradiction, I'm not sure the right word there. Contrary. This 80-year-old patient has a bit more going on. Although you've been told they're aphasic, you will find them mumbling and febrile. Furthermore, they haven't been seen normal since 10 o'clock the night before. Given all of that, the patient doesn't qualify for stroke bypass, and furthermore does need a workup for this febrile insult as well as acute management of a decreased level of consciousness.
Right. I mean, this person looks like he has, depending on what their eyes do, it looks like a GCS less than 10, and that they're mumbling, only making incomprehensible sounds, as well as only withdrawals to pain. So this person has an airway issue and should be best managed at a local hospital. Although, by itself, aphasia alone is an indication, but GCS less than 10 is a contraindication.
Yeah. But this is definitely a case that can prevent some confusion and some trouble. The third case is an interesting case from multiple perspectives. The patient does have a unilateral neurological deficit, and that would make you concerned with stroke. But as you rightly identified at the beginning, his complaints of chest pain makes a much higher concern for him having some form of cardiac issue or a dissection issue. The hypertension also throws things off, because as we discussed during the webinar, hypertension is the common blood pressure in a stroke. But again, things just don't seem to fit, and his main complaint throughout all of this is chest pain. So I think you were quite right at the beginning to identify cardiac issues as number 1, and then once assessed at the nearest facility, if they need to activate stroke bypass later, that may happen, but you were fairly right in the way you assessed this patient. So the take-home points is that you need to look for unilateral neurological deficits. I'm sort of sick and tired of that word, and you're probably sick and tired of me hearing it. That's going to be the key to any exam. You want to ensure the patient is stable enough so that you can bypass the closest hospital as well as an assessment by an emergency physician. And when you're estimating the time of onset, you need to use the longest possible time. This is because thrombolytics do carry a risk to them, and we do not want to be causing more harm than good to these patients.
In essence, what we're doing is we're providing them a high-risk thing, saying you have profound motor weakness or aphasia, and we're going to administer a therapy that has a good chance of improving that, but also carries with it a significant chance, not an insignificant chance of causing further bleeding. So everything has to be just perfect within the protocol to make sure that you're giving it to you with the best chance at optimal outcome and the best, safest way for the patient. So knowing that time of onset is absolutely critical to have the neurologist make that decision as to who they should thrombolyze. Excellent point. Well, Bourke, thank you very much for doing this webinar for us. And as always, as Matt has alluded to, the Ask Mac website is always active. So if you have any questions that didn't come up during the webinar today, please feel free to forward those to us, and we'll get those turned around back to you. And so on behalf of the Southwest Ontario Regional-Based Hospital Program, Bourke, thank you very much for providing this webinar to our paramedics today.
Not a problem at all.
And
Thanks for your attendance.
just to jump in there, we do have a couple minutes left here, and there's two quick questions. One
Great.
question was, do children present any different than the elderly? And you know, we hear about stroke, and we often do think of this as being an older person's disease, but what about children? Do they present any differently, or are there any types of diseases that may put a child more at risk for having a stroke?
That's a great question. And in fact, 3 years ago when we did our webinar first on stroke bypass, by speaking with Dr. Chan, you'll notice that at that time there wasn't actually an age cutoff on the stroke bypass protocol. So therefore, stroke in the young is a very rare phenomenon. And usually their children, although they can have stroke, most of those tend to be embolic or hemorrhagic, not necessarily thrombotic. Because children just simply aren't of the age to develop the severe atherosclerotic disease that our elderly patient population do. So given the embolic or hemorrhagic components, the neurological examination is actually going to be very similar, same with the hemodynamic pictures, but the etiologies are more embolic and hemorrhagic. They don't necessarily, there's not a great case series or a large experience with thrombolysis in children, in the young children. There was a case actually in London about 3 or 4 years ago, but that was one of the first cases ever. So at this time, given the number of stroke mimics and how rare stroke in the young actually is, it's best to go to your local hospital and get the work up there. And we can always secondarily activate the stroke bypass if warranted from that point. Great question.
And one last question here. Just someone wants to confirm, if a patient does have a DNR, can they still transport under the stroke protocol?
Absolutely. So many people live active, healthy lives, and they are DNR patients because they decided that they want to be a DNR based on their past health, their past experiences, but they're not necessarily in palliative care or terminally ill. They go to movies, they enjoy their life, they have family and friends, and yes, if they have a debilitating stroke, they're not being a DNR does not mean that they are a contraindication to transport. And remember as well, you as a paramedic transporting the patient to the stroke center doesn't mean necessarily that the person is going to be thrombolyzed. Of the patients that are transferred into the bypass protocol, only about 5 to 10% of them actually ultimately have confirmed diagnosis of stroke, come in under the window, and wind up getting thrombolyzed. So a very small percentage of them actually do get thrombolyzed. That discussion shouldn't, whether or not the DNR patient should have a stroke thrombolyzed, shouldn't have to be forced to the paramedic with their family members on scene in such a short time window of your on-scene time of 12 minutes. That's best done once we have the information, once we have your CT back. We can make a discussion with the family and the patient themselves, the risk benefits, and they make an informed choice. And if thrombolysis is the plan, they can engage in that. So a DNR is not a contraindication to be part of the stroke bypass. A palliative or a terminally ill patient, which is a vague diagnosis and difficult to come across, but nevertheless, a DNR by itself is not a contraindication to thrombolysis.
Another question here, Mike. In regards to case study number 3, if the patient is complaining of chest pain and has obvious unilateral weakness to that leg, or sorry, that arm, would you want to withhold ASA or would you want to give it?
Great question. So our teaching in terms of aspirin administration is suspected ischemic etiology chest pain. So chest pain is suspected ischemic etiology. So my question is, if someone has a neurological finding and a sharp chest pain, that's not typically what I'd expect someone having from a pure ischemic etiology chest pain. So in that situation, documentation is important on behalf of the paramedic and your EPCR. We would totally support you with holding aspirin in that patient because you're thinking this is an alternate diagnosis. Not many people with cardiac disease and cardiac chest pain develop arm weakness or arm loss of sensation. They will have radiating discomfort to their arm, but not a neurological finding. So if you have neurological findings in chest pain, think alternate diagnosis besides ischemic chest pain, and I would withhold the aspirin just as long as it's documented very well in your EPCR so we can follow through as to what your thinking is when we audit you respectively. Great question.
And a question, kind of a downstream question, you know, once the patient makes it to the emergency department or the stroke center, do the neurologists at all consider an upper age limit for giving TPA or a lower age limit at all?
Great question. The short answer, all those things are factored in, and including other things like blood pressure. Like our filter for transport is very different than the checklist the neurologists use for thrombolysis. They don't have an absolute cutoff as to where they thrombolyze. but nevertheless, they do factor in. If you look at case series, the older you are, the higher your blood pressure, the gender, all those things factor in your likelihood of bleeding. So therefore, at this point, there are a higher risk, and that just blends into the informed consent we provide the patient versus it being an outright contraindication. So it's not that you hit a certain age, no more license for you. It's more of a, we can do it, but your risk is this. It's a bit higher based on our experience. Not sure if it's the best plan, but nevertheless, it also depends on how severe your current deficits are. If you have nothing to lose because you're so profoundly impaired by your stroke, well then maybe you do justify the higher risk and should engage in thrombolysis. And that is the very, very difficult decisions that the neurologists and family members must face when they engage upon the stroke bypass protocol. So great, great question.
Well, that's all the questions we have for today's webinar. I want to thank Dr. Lewell and Dr. Tillman for presenting this today. And we hope that all members of the audience found it useful, and we look forward to you joining us in future webinars. Thank you very much.